¿Todos tienen ya su auricular? La verdad es que estoy muy contento de estar sentado el día de hoy con Bob Forster. Desde el día en que supe que él iba a venir al Congreso, estaba muy contento porque él ha trabajado con algunos de los más grandes deportistas, particularmente uno a quien yo admiro muchísimo, bueno, dos en realidad, y ha trabajado muchos años con ellos. Uno de ellos es Pete Sampras y el otro es Jackie Joyner-Kersee, para mí la mejor atleta que ha existido en toda la historia. Pero independientemente de eso, el miércoles que estuvimos en el taller, tuve la oportunidad de darme cuenta que tenemos otras cosas en común. Una de ellas es que Bob es un ciclista y, aunque no lo crean, él ya hizo una ruta transalpina, cruzó los Alpes ya varias veces en bicicleta. También han de saber que Bob, además de trabajar en Santa Mónica con los mejores atletas de velocidad en el mundo, fue luchador, pero no de esos luchadores que están pensando de enmascarados, sino fue luchador grecorromano. Y la verdad es que eso es lo que nos gustaría que nos platicaras un poco, Bob.
Yes, my introduction to sports was as an athlete and to sports medicine as an athlete. I wrestled in high school in the United States and then in college, and actually went back to wrestling at age 45 as a veteran or master's wrestler, which I actually don't advise. And so wrestling taught me a lot of the discipline and the focus that I've taken to physical therapy. It also, of course, gave me insight into athletes, the way we train, the physiology, and it made me hungry to learn more on how to help athletes maybe overcome some of the problems that I saw in athletics, which is basically that the coaches in America and the approach to wrestling and all sports needs to be more scientific. And so I've dedicated the last 33 years of my professional career as a physical therapist to be sure that I always give back to the community and work with local coaches at the high school level and the football coaches and the football clubs. So I advise all of you as physical therapists to be that person, that point person in the community that can teach stretching exercises and teach strengthening exercises to both physical education classes. You can make friends with the coaches and the physical education teachers and be that person that shows up every year to teach them stretching. And it's a great reflection of our profession, and we have that knowledge. Also, my school at Stony Brook University, they taught us that there's no one better than us to teach fitness. We know how the body breaks. We know how the body breaks down and gets injured. And so therefore, we should design fitness programs that have a built-in bias to strengthen and shore up the vulnerabilities of the human body. For instance, we know the shoulder, how it gets hurt. The spine needs to be protected and supported, the knee, the hip. And so if you devise a strength program, you should have a built-in bias to strengthen the small muscles that need to be strong to stabilize these joints. So we are more than clinicians. We are community members that should represent our profession and share our knowledge freely. There's never, in my opinion, there should be no caution of sharing your knowledge. It will always come back to you. And it's good for your business, and it's good for our profession.
Tell us just 1 minute about your Transalp cycle. Le pedí que hablara un poco acerca de cuando cruzó los Alpes en bicicleta.
The challenge of a 7 or 8 day bicycle race across the Alps is to understand the entire physiology. So in addition to my physical therapy training, I've done a lot of self-training in exercise physiology. In fact, we have a center in Santa Monica, Phase 4 Health and Performance Center, where we focus on teaching athletes to train properly with science, specifically periodization science. So it's great pleasure to take the science and knowledge that I have both to maintain structural health and to improve my physiological fitness and take it to a challenge, like an 8-day race across the Alps. It's 60,000 feet of climbing, about 2,000 meters over the whole week, and almost 400 miles. And so to apply the science to yourself is a great way to learn how it works, and it'll make you a better clinician so that you can support your clients better understanding that. And when I come to Puebla and the bus ride from Mexico City, I thought I was back in the Alps. It's very beautiful here, the mountainsides, the snow on top of the volcano. I thought I was back 3 weeks ago climbing the Alps. So I advise all you to get very active. You all should be doing the very minimum of stretching and strengthening every week, and take up a sport like cycling, which is very easy on the body, and you can do it until you're old, and maintain your fitness and learn how athletes need to train. And it was a great experience being here, and this whole month has been exciting, from Europe to Mexico, with a stop in Las Vegas. And now I have to go back home and work.
Muchas gracias, Bob. Bob Forster nos va a hablar hoy acerca del foam rolling.
Thank you. I appreciate you getting up so early in the morning to hear me speak. And I want to cover some topics today that I think are important adjunct to your therapy, as well as another tool for you to give to your patients so that they can take responsibility of their own health. In our physical therapy office, we are an exercise-based clinic that uses hands-on techniques, manual therapies, and modalities to speed up the process. But we truly think it's exercise fixes people, and the body is a mechanical structure that needs mechanical treatment. So teaching people the importance of stretching, strengthening, teaching the people the importance of ergonomics, how they use their body, is a big part of what we do. We want to empower our patients to be an active participant in their care. They're not going to be a passive recipient of our care. They're going to be part of the process. And it puts responsibility on them, and it makes them a willing partner in their rehabilitation. It gives them tools to fight their pain, and it gives them tools to stay healthy. The foam roller has emerged in the last 10 years and has become a very important part of health maintenance, and again, putting the responsibility on the patient and on the athlete. The difference between my Olympic athletes now that we treat, including Allison Felix, who won 3 gold medals last year in London, and Dawn Harper, who's a gold medalist and silver medalist in the hurdles, is they do a lot of their own maintenance. The difference between them and Jackie Joyner-Kersee and FloJo back in the 80s is the athletes today travel with their foam roller. They travel with balls and other devices to work out their own problems and knots in their body, and they're not relying so much on people to do that for them, and that's impressive. You can follow us on Twitter and Facebook, and also if you go to our website at Phase 4, let's see if I can find that, you can receive our email newsletter. It comes out every week. This is a picture of our physical therapy office in Santa Monica. We have a pool and treatment rooms, obviously. Last night, yesterday afternoon, I had the great pleasure to visit the recovery center, and I was very impressed. Very modern, very beautiful, very well thought out, the flow. And that's one of the things we strive for when we designed our office, to patient flow and make patients feel comfortable, a place that they want to go that feels positive. Some of the things that we do at Phase 4, running gait analysis and strengthening programs. These are some of the athletes we've worked with. And these elite athletes, they're only 10% of our practice. Most of our practice is everyday people, active people. But the benefit of treating elite athletes is that they're very finely tuned. So when they have a problem and you make a physical therapy intervention, a new stretch or new strengthening exercise, or you apply a new treatment technique, that you see the results immediately. And the rest of us, mere mortals, it takes time for these techniques to work.
So they're like a learning laboratory. You apply your techniques, you see improvement. That gives you the confidence to stay the course with your patients, that the same techniques will work. It just takes a little bit longer. We travel in our Phase 4 mobile lab, where we can do testing at various sites or support athletes. This is the tour of California, and we were there to support some riders. Our basic philosophy covers these 4 pillars of performance. And if you keep your eye on all aspects, all these 4 aspects of performance, your athletes are going to be more successful and suffer a lot less injuries. Structural integrity is part of what we're going to talk about today. That's how the body works mechanically, how well it stands up to the stress of workouts and training. Basically, this is your strength and flexibility program, and everyone should have a strength and flexibility program. It might be, for the average population, it might be very minimal stretching and walking, and of course, for advanced athletes, they train sometimes 10, 12, 15 hours a week. Metabolic fitness relates to how your body makes energy on a cellular basis. It's your metabolism. You know about aerobic and anaerobic fitness. It's important to understand those principles and how each athlete and each sport trains those systems and what needs there are. So another important goal and role that you play in the community and with sports teams and athletes is understanding the requirements of their sport. What are the metabolic requirements? Do they need to have a large deal of aerobic fitness, anaerobic fitness? And this way you can interpret those sometimes complex principles to the coaches and the athletes. Nutrition, of course, is important, and it's a science that's in its infancy, but there's a lot of information coming out now about a better way to fuel an athlete's life and your own, fuel the workouts and fuel competitions. So it's important because this will sabotage their performance. And so it's important that you understand, and you're often the one that will be the conduit between science and the athlete and the coach. And of course, technique. Technique is everything. When athletes have good technique, they can overcome many physical limitations. And a very prominent story in my mind is working with Jackie Joyner-Kersee at the Barcelona Olympics. And she had a very unstable ankle for years. And we worked on strengthening it, making it work better. And she was going jump for jump with an athlete from Germany named Heike Dressler, who was destined or predicted to win 4 gold medals at those Olympics. Well, Jackie had other intentions. And in the long jump, they went jump for jump. Each time the one jumped further than the other. And finally, it was second to the last jump. And Jackie, on the long jump, hit the board wrong, and her ankle turned violently. And I couldn't tell, I had about 2 minutes to assess if it was fractured, if it was sprained. I immediately taped it up. And I'm like, her coach is her husband. And so I said, Coach Kersee, we have no idea the state of Jackie's injury right now. We don't know if we should take this last jump. And his point, he turned to her and he said, if you execute that jump right, this ankle will be fine. The reason you turned your ankle is because you did not execute the mechanics of the jump properly. And that taught me a lot, because that ankle, with a lesser coach and a lesser athlete, never would have made it through that gold medal. She ultimately went out and put the final jump past Heike Dressler and won the gold medal. So it brings to mind that technique is everything. You need to know the technique of the sport. And again, you might be the person that teaches the athlete and the coach the biomechanics of that technique. The coach will know what the athlete wants to do. You should analyze the biomechanics and be able to help them understand what the body needs to do and how it needs to perform. So, foam rolling. Foam rolling is basically a self-myofascial release technique. I believe in self-massage. Athletes by nature need to be and want to be self-sufficient. So to give them another tool to maintain their health, so that it reduces their anxiety, so they're not relying on a trainer or a massage therapist to keep them healthy and recover. They give them their tool and let them use that science. So one of the things we've been talking about all week in my lectures and seminars is that we're constantly training to create adaptation. that the human body is a great tool at adaptation, and it adapts to the stress placed on it. The connective tissue, as you know, is stressed during workouts and becomes damaged. And that damage then repairs, and the athlete's stronger. So the connective tissue breakdown, repair, remodeling, scar tissue remodeling, to turn into a functional, stronger structure, is the adaptation we're trying to foster, we're trying to propagate. Specifically, if you remember from your studies, this is called Davis's law of soft tissue adaptation. If you stress the connective tissue, collagen elements, tendons, fascia, it will break down some, and then it'll repair and be stronger. What the foam roller does, as well as massage, as well as stretching techniques, is help the scar tissue form in a more functional pattern. If you think about a muscle being muscle tissue, red, blood-rich tissues, each muscle fiber surrounded by connective tissue, a bunch of muscle fibers bundled together, wrapped in connective tissue, and then muscle bundles together, wrapped in the whole muscle, and then muscle groups are surrounded by more connective tissue. So really what we do all day long as physical therapists is deal with connective tissue and how it's adapting to the stress of the workout or adapting to repetitive motions at work or in someone's life. Anything we can do to help that soft tissue adapt faster and be a more meaningful scar is important. So think about the muscle. I'm very impressed that the students of IPETH are familiar with Cyriax techniques, Cyriax cross-fiber friction massage, and how that addresses the connective tissue scarring that occurs in injury and occurs in training. So if you think about the muscle as a three-dimensional, blood-rich tissue that has like scaffolding in it, it has framework of connective tissue. When it becomes stressed, the problem is the inflammation makes the scar tissue and the muscle fibers stick together. And if they stick together, they can't do what muscles do, which is to shorten and broaden. So our job is to restore function to that muscle. I've read things that you shouldn't do deep massage right before an athletic competition or a practice. That's not true. If you can restore function to a muscle or a joint immediately before someone competes, they're going to compete better. So I've done deep tissue massage right down to the bone seconds before an athlete has stepped on the track and set a world record or win a gold medal. So the foam roller is something that they can do to flatten the muscle out, break the adhesions between the muscle fibers. In my training, my bicycling, I discovered the use of the foam roller more effectively about 3 years ago, and I fired my massage therapist. So that every day I'm responsible for preparing my muscles for my workout. So I always stretch first, then I use the foam roller, come back from my ride, my bicycle ride, I stretch again and use the foam roller. When I'm doing heavy training, I might also do an ice bath afterwards to help with the inflammation so more scar tissue doesn't form. But the foam roller is a great way to flatten the tendon, flatten the muscle, spread the muscle fibers out, break the adhesions between muscle fibers, restore function. I would have chronic injuries in certain areas every year when I ramped up my training for the Transalp Challenge. And I would have massage therapy and treatment, and I would be able to maintain some form of function, but often was in pain until I discovered the foam roller. Now, when you first get on a foam roller, it hurts. There's no denying it. Second time you get on it, it hurts about half as much. The third time you get on it, it's about a quarter as much. And then you just start maintaining that muscle health, barely hurts at all. In addition to these flat foam rollers, you need to research and find the rumble roller. The rumble roller is like here, but it has big knobs on it. I suggest you start with the flat surfaced foam rollers. And then progress to a harder one, which is called a grid. It has grid pattern in the foam, and that binds the tissue for you and makes it more effective. And then finally onto the rumble roller, which has big knobs and really gets in there and works the muscles. So injury prevention, soft tissue adaptation, Davis's law. These are concepts that are very akin to what we're doing with the foam roller. We always stretch before. because you get into some very precarious positions on the foam roller. So it's important you've stretched before to make sure you protect your back and your other joints. And when you're on the foam roller, you always want to maintain 3 points of contact with the ground. So you can modulate how much weight you're putting into the foam roller. This is what you need to teach your clients. I believe in using the foam roller from distal to proximal, just like we do massage, to facilitate, in addition to connective tissue treatment, the foam roller pushes waste products out of the muscles, out of the capillary beds that are housed in the muscle, out of the blood vessels. So going from distal to proximal will assist the return of these metabolites out of the muscle and back in the bloodstream, as you know. If you find painful spots in the foam roller, you can spend a few minutes going over it. But basically, I'm going to show you to hit each muscle part of the muscle 3 times. You come from bottom to top, back to bottom, back to top. That's 3 strokes. Then you move, you hit the next area of the muscle, again 3 times. When you're done, you'll feel looser, you'll feel better. Might be a little lingering soreness somewhere, but that's as expected, but you'll probably always feel better after the foam roller. Rollers shouldn't cause bruising. And of course, we should avoid bony prominences and areas where you know there's a bursa between the bone and the soft tissue above it, in the superficial bursas. So here's a technique of using the foam roller on the hamstring. And you notice that there's 3 points of contact, at least, which is both hands on the ground and his right foot is bearing weight on the ground. So he can modulate how much pressure he's putting on his hamstring. It's important to go from the very beginning or insertion of the muscle all the way to the origin. Don't just work in the mid-range. Go all the way up, all the way down by moving your body and the foam roller moving, and then move on to the next muscle. Here he's doing the calf, and you can do straight down the middle. You can turn your leg and go lateral gastroc and soleus. Go on the inside, do the medial gastroc. Here he's working the piriformis. This is where, if you can see, there is quite a bit of stress on the back. So you don't want your patients with unstable lumbar lesions that have not yet been quieted and settled down. You don't want them sitting in this position, right? You can imagine the forces on, this is one of my therapists, you can imagine the forces on Ron's lumbar vertebrae and more specifically the discs. So you have to be sure you've cleared your patient before you show them this. This is something I often show patients when they're done with rehabilitation as a tool for them to use when they no longer have my hands to work on them, not in the acute stage. Here he's getting a very important muscle group, the piriformis, gluteus medius and minimus, iliotibial band, the tensor fasciae lata. These muscles are very tight and they're very hard to stretch. So the foam roller is great to hit muscles that are difficult to stretch. Here he's doing the quadriceps. I actually prefer not doing both quadriceps at the same time. I would do my own one quad at a time, so my opposite knee is on the mat and helping again support my weight so I can modulate how much weight I put into the foam roller. Here, very important, the top of the quadricep, the rectus, the one quadricep that crosses the hip, is the rectus femoris. Very difficult to stretch, and it likes to get real tight and contractures, which affects the pelvis and the patellofemoral function. So to get and let that foam roller sit right in that kind of a trough in between your anterior superior iliac spine and the femur, and get in there and really stretch that muscle and break down adhesions. Here, Ron is hitting the adductors, the inner thigh muscles. Very effective, very big muscle group that should be trained actively because it's very important in almost all running and weight-bearing movements. And Ron's keeping that adductor healthy with the foam roller. IT band. The IT band, if you do cadaver dissection, you see that the iliotibial band is a very thick band of fascia. The IT band doesn't stretch. When we do stretches like this, see people doing this for the IT band? The IT band doesn't stretch. If you took it out of the human body and you hung a 60-pound weight on it, it would stretch maybe a millimeter. More importantly is to free it up off of the quadricep lateralis, especially in cyclists. This quadricep lateralis really develops in a cyclist. And that friction between the iliotibial band creates inflammation and scarring, and it often gets stuck down to the lateralis muscle. So more important than stretching it, when we stretch, we want to get more flexibility in the IT band, we stretch the glute muscles, and we stretch the tensor fasciae lata that feed into it. The best you can do to free up the IT band itself is to use the foam roller. You go up and down. Once you find a sore spot, we go back and forth in a cross-friction type of direction. Again, based on Cyriac's principles of breaking adhesions. So this is one of the most important uses of the foam roller. Here, Ron's doing the front of his shin, the anterior tibialis, the extensor digitorum longus, extensor hallucis longus. Really important area, again, that's difficult to stretch. Very effective to use a foam roller and get a lot of the same results. Ron's lying with the foam roller vertically on his spine. And this is a very common use of the foam roller, so you can open up and stretch the pectoralis muscles and also straighten out and flatten the spinal curves. So people who have excessive kyphosis in the thoracic spine, they lay on the foam roller and they do a pelvic tilt and a chin tuck. Think about taking a string of spaghetti and pulling it tight at both ends and flattening it out. It's a lot of value to maintain spinal health and also stretch the pectoralis muscles, which is, as you know, critical to posture and critical for cervical issues. And Ron's then rolling back and forth and moving over the rhomboids and erector spinae on either side of the spine. And reversing the thoracic curve. So now he's using the foam roller, and this, by the way, is the grid roller that has a pattern of crisscross in the foam, which helps bind the tissue and makes this even more effective. And to reverse the kyphosis, which is under strain all day long in postures and sitting and people's postural deviations, it's really valuable to lay back. I even prefer, if the cervical spine is sound, to let the head back and the arms over the head and really reverse the thoracic curve, which, as you know, is taking all this type of stress. When the thoracic kyphosis is exaggerated, then the neck has to be deviated just to see. A lot of that kyphosis and deviation comes from tight pecs and a very stiff and kyphotic thoracic spine. For cervical patients, if you get more mobility in the thoracic spine, you're going to help their neck. So here, Ron is showing if you had a patient that did have a cervical problem, that they're holding their neck but still getting some mobility out of the thoracic spine. I do not suggest using the foam roller on the cervical spine. It's just too delicate of a structure. Same with the lumbar spine. I'll go up and down the lumbar spine really quickly, and that's it. If a patient's putting most of their body weight on a sore segment of lumbar spine, they can have trouble. What I do suggest, though, is 1 or 2 up and down on the lumbar spine, but then to turn sideways and use the foam roller to release the quadratus lumborum. My experience, every back patient has tightness in the quadratus lumborum. It always spasms to try to protect the back. The quadratus lumborum is basically nature's own corset or back brace. When your back is sore, your quadratus spasms, so you limit your motion. That's all well and good, but we're now able to obviously think past these protective mechanisms of the body, because if it stays tight and spasm, it's going to get weak very quickly, and it becomes a great source of pain even after the spinal condition is improved. So releasing the quadratus lumborum in your practice with your hands and your modalities, but also teaching patients to release it on a regular basis is going to keep their spine a lot healthier. Here, Ron is releasing the latissimus dorsi, very important as well. Once posture deviates, the latissimus dorsi facilitates more deviation, meaning once they become kyphotic, the latissimus dorsi is acting to pull the body further in this direction. When you're in good posture, it doesn't do that. But once the posture becomes deviated, then we see it becoming a pathomechanical problem. So releasing the latissimus dorsi is very valuable for all of your cervical and thoracic issues. Now Ron's getting in the posterior shoulder. And we all know this is an area of the body that is prone to many problems. Most of your shoulder problems, in my opinion, come from the posterior rotator cuff, infraspinatus, teres minor, and the joint capsule is weak and tight, and it changes the position of the humerus on the glenoid, and it moves it forward and makes it more likely to create impingement. To me, that's the basic mechanism of all shoulder issues. Anterior instability, posterior too tight, too weak. So releasing those muscles, and on a kind of an angle, relatively painful, but it really, as soon as you open that up, you feel your whole posture and your shoulders sitting in a different position. So what happened there? Not sure what I hit, sorry. The other way. Okay, I guess that was the end. So, foam roller, very important tool for you to teach people, in my opinion, in the final phases of rehabilitation, because when they're more acute, in the first phase and the second phase of rehabilitation, it's better that we do a lot of this work for the client. Once the patient's condition is stable and the symptoms are under control and they have a stretching and strengthening program to maintain their health, I teach them this on the way out the door as a tool to maintain their own health. And I think that they'll appreciate that and think highly of you and your techniques, and it'll enable you to gain more trust from your clients. So to summarize, foam roller work is just part of the recovery and adaptation process that we're looking for in the training cycle. It's a great tool for healthy athletes, and it's a great tool for athletes who've been injured and coming back after rehabilitation. Again, it's dealing directly with the connective tissue elements in the system, the perimesium, epimesium, the fascia, the tendons, the scar tissue that forms, creates dysfunction, and like Cyriax cross-fiber friction massage and other manual massage techniques, the foam roller will really assist improving adaptation for the athlete. So I think we can take questions. So Alejandro has asked me to demonstrate some of the techniques. I think I'll do it on the floor right here, so you might have to stand up and see it in action. Yesterday in a workshop, I showed the participants that they can do a stretch before and after their workouts that only takes 4 minutes, and you can hit the entire body. Many coaches and athletes say, I don't have time to stretch. And I tell them, if you don't have time to stretch, you don't have time to work out. It's an essential part of your workout. Another point that I neglected to make, which would probably a good time to do so, is I would ask you, how many people here brush their teeth every day? How many people brush their teeth? How many people floss? Okay, how many people stretch every day? So you see, people spend more time taking care of their teeth than they do the rest of their body. It's your job to teach people that they need to do work to maintain their body. Our body wasn't meant to be still. Even if you're an athlete and you train 90 minutes a day, which is a lot for a recreational athlete, you're sedentary probably about 20 hours. If you count up all the rest of the time that you're not moving, it's probably about 20 hours a day. You know, you sleep hopefully for 8 hours. You get up and you have breakfast, then you get in your car, you're sedentary. You walk to your work, you sit at your desk another 8 hours, maybe you walk at lunch. But if you add up all the time you're still, it's probably about 20 hours a day. The human body wasn't made to be still 20 hours a day. We're creating so much dysfunction by the very posture that you're in right now. So you need to teach. This is the job of the physical therapist. You need to teach people that they need to maintain their body just as they maintain their teeth. And the Dental Association has done a much better job than the Physical Therapy Association at teaching people to take care of themselves. So just as your teeth will decay if you don't take care of them, teach people their body will decay. You know, most of the aspects that we associate with aging is really just disuse atrophy. People stop moving when they get older, their body stops working, and it seems like they're an old people. If you keep in mind that I did a triathlon last summer, and a guy finished who was 93 years old. Finished a whole triathlon. I see 70-year-old ballerinas with better flexibility than probably most of the 20-year-olds in here. So in our culture, a lot of times we do sports when we're younger and we're supposed to be active, and then we stop being active. Even your digestion doesn't work if you're not moving and walking, much less your joints. So it's your job as a physical therapist to teach movement. As you know, movement is health. Movement is life. That's what we do. Exercise is medicine. Every day we see research to show that exercise does the same thing that a lot of medicines do. Improve metabolic health, obviously improve physical health. So we need to be that conduit, not the personal trainer in the gym. They don't have the background. They don't have the science. They have a lot of enthusiasm. But I see here in Mexico the young therapists with a lot of enthusiasm and the scientific knowledge to be the conduit between science and the community. You're the one less intimidating than a doctor to go to a physical education class, teach stretching, go to the local football club, talk to the coach about how you can prevent injuries by teaching their athletes to stretch, to use the foam roller. You should be the one teaching the public about the science of health and fitness. So your education certainly empowers you to do so. You'll make a lot of friends, and you will stimulate a lot of business as well. We give talks and lectures at the local running store. That help the running store promote a lecture. We come and talk for 15 or 20 minutes, maybe an hour, about the various aspects of training. Go to the bicycle shop. Go to the local Rotary Club. Go to any other civic association. They're always looking for speakers. Learn to become a public speaker. Learn to get the knowledge that you're taught here at IPATH out into the community. And I think it's rewarding. You make great friends on a very positive note. And as I said, it's really good for business. So I will demonstrate really quickly. Now, I did my stretches this morning. Not really. But pretend I did my stretches this morning. I did some stretching last night, I think. Okay, you might have to stand up to see this.
So I'm going to start with the quadriceps, as I indicated earlier.
Lo van a filmar, así que pueden permanecer sentados o mirando de atrás para que no se...
I'm starting all the way at the bottom, right above the patella tendon, right above the patella, and going all the way straight down, right down the front of the quadricep, the rectus femoris. When I get up to the top, right at the anterior superior iliac spine, I'm going to let that foam roller sit there and stretch that muscle. The rectus femoris often gets a contracture from here to here where it gets too tight. It's very difficult to stretch it. But in the foam roller, pushing it and lengthening it because it has to go over the foam roller. Remember I said 3 points of contact? 1, 2, 3. So I'm here. Thank you. I'm all the way down. When I get to the top of the rectus femoris, I might go back and forth this way. Cross fiber, friction massage, a la Syriacs. Back up. That was 2, 3. Now I'm going to turn and get the quadricep lateralis, actually starting at the tensor fascia lata at the hip. Up here it's very tight, very difficult muscle to stretch. So I'm going to go back and forth, cross fiber technique, and then go on the lateralis. Very important muscle for cyclists and runners to free up the IT band as it sits on the lateralis. So that was 2. Now I'm going to go directly on the iliotibial band, starting all the way down at the femoral condyle, epicondyle, and go down IT band. If I find a tight spot, I'm going to go back and forth this way. And I can do that in a stepwise fashion all the way up the IT band and free that off the fascia that covers the quadricep lateralis. When I get to the greater trochanter, I'm going to be careful. A lot of people have soreness in the trochanteric bursa. So if they're sore there, it's probably not a good area to rub back and forth. And then I'm going to go lightly, go over the trochanter. And now I'm on the gluteus medius and minimus, specifically the minimus. Take it all the way up to the top of the iliac crest, where it originates. And I might stay right here, go forward again, hit the tensor fascia lata, go backwards, and get more of the gluteus medius, and then onto the piriformis. Of course, I'm going through the gluteus maximus, piriformis, and all the deep rotators, deep in the glute. But make sure you go all the way to the top, to the iliac crest. That's where people are going to find a lot of soreness. You're going to find a lot of soreness in people is at the proximal aspect of the gluteus minimus and medius. Then I might go directly on the back of the glute. And then I'm moving on to the hamstring. So I get on the end of the foam roller. So this part is unencumbered. I'm going to get all the way up on the top at the origin of the hamstring, all the way down to the knee. That's 1, 2, 3. Turn a little bit to the outside. I'm on the biceps femoris. Biceps femoris, very important. The short head of the biceps femoris lies under the biceps femoris tendon, correct? That's a problematic area. When I get on that area, I'm going to go back and forth to free up the biceps femoris short head insertion and origin. I should say origin. In the middle of the biceps, I might find soreness. I'm going to go back and forth. Free that up. The inside is a little tricky and very important. So the semimembranosus is on the inside. So I'm going to come down. I'm not quite on the adductors, right? I'm not quite on this side. I'm on a 3/4 angle. And so from here, with the knee bent and this leg bent, I'm going to go down that medial hamstring column. Again, 1, 2, 3. If I find a sore spot, I'm going back and forth. It's important to try to, pick up and get some weight bearing on that. Then it's directly onto the adductor itself. And I might do that by moving this leg backwards. And I'm down on the medial corridor of the adductors. Adductor magnus, longus, gracilis. And I take it all the way up, pubic symphysis. And again, there. And then the calf. Start the Achilles tendon. I can start the Achilles tendon, move downward, all the way to the top of the gastroc, which, as you know, crosses the knee. Come back, lateral, gastroc soleus, medial, gastroc soleus. Find a sore spot, go back and forth. Now the rumble roller, like I said, has big knobs on here. That digs in the muscle, really binds the muscle, and you can get a really good grasp and free up adhesions and tightness. This has eliminated the chronic problems I've had with the popliteus. Remember the popliteus muscle, deep under the top of the calf? Its tendon actually comes under the biceps femoris, under the lateral collateral ligament, and attaches here. A lot of times people come in and they say, physician said I have IT band syndrome. They've been injected in the IT band. Doesn't go away. Because they missed the involvement of the popliteus. So the popliteus is your job to know where it is, find it, palpate it, and see that it comes here. I had chronic problems with the popliteus with my bicycling. So first I improved my bicycle fit, my position on the bicycle. Still, when I got into 10, 15 hours a week of cycling, my popliteus would act up until I learned to release the biceps femoris tendon, and short head. Releasing the biceps femoris, I think the biceps femoris head gets contracted, it externally rotates the tibia, and it puts the popliteus on chronic strain. So I learned to release the short head of the biceps and the biceps tendon on my foam roller. This year I trained for Transalp, I had no pain in the popliteus. That was a 15-year problem that I could never solve. Strengthening, stretching, finally solved it on the foam roller. Same with the VMO. Had chronic problems with the sartorius and the VMO where they cross. Chronically scarred down from cycling because sartorius is a big cycling muscle because it flexes the knee and it flexes the hip. And you do that on the pull-up on the bicycle. And so once I started foam rolling in there, my chronic VMO and sartorius problems went away. So I'm a big believer. Then you saw, I might fall asleep here. So what I was saying before is I'm going to do a pelvic tilt and a chin tuck, and I'm going to try to straighten my spine out on the foam roller. I can go back and forth a little bit, still on the spine. Then I can go off the spine on the rhomboids and the erector spinae, trapezius, and then the other side. Whoa. Don't drink and do the foam roller. Too much tequila. Okay, so now we're going to go transverse. We're going to put the foam roller perpendicular to the direction of the spine. I'm going to start in the mid-back. If I have cervical issues, you need to support the head. This is still reversing thoracic kyphosis. If I have a healthy neck, I'm back here. And you'll get cracks and pops. I don't suggest you go anything fast. I wouldn't go past, T1, T2 into the cervical spine, but T1 and 2 are important to mobilize, and then it's all the way down, you'll get pop, 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 pop. When you get to the lumbar spine, quick motion on the lumbar spine, but then turn and release the quadratus lumborum just quickly. Don't stay here too long. And then the other side. If it's tight, I can also go back and forth this way. It's hard to do the pecs, but we'll try. Release the pecs. Arm here. I'm kind of on an angle. I'm approaching the foam roller on a 45-degree angle. And I release the pecs. And you know the pecs are a very important muscle group for posture and for function. The lats sideways and the posterior shoulder. Insertion of the lat, the back of the scapula, the posterior, the lateral border, the scapula, all the way down the lat, and then turning back and getting on the posterior cuff and really working it. It hurts. It hurts, but when you get off, you really feel a lot better. Your posture, your shoulder opens up. This is an important tool to use for young therapists. The IPET school has done a very good job at teaching you the basic science in this Congress. The more advanced hands-on techniques, I'll be honest with you, they take years to develop. You have to start now. You have to put your hands on a lot of people. Work on your mom, work on your brother, your sister, your girlfriend, your boyfriend, your cousin. get experience, but the more systematic approach you have to care, where you're giving patients tools to treat their own problems, the more effective you're going to be until your hand skills become more developed. So I'm advising the school and your students to use a system, treat in phases. The first phase is to make sure you're controlling the pain before you move on. So in the beginning, we have a real advantage as physical therapists. It's not a life or death situation. It's not like the emergency room. You don't have to decide someone's fate like that. You have several visits to figure out what's going on. Do a good primary exam and evaluation. Start with some very basic treatment techniques, joint protection, get them off the sofa, get them sitting on lying, propping up in bed. Those are the two biggest problems I see with shoulders and spines. Lying on the sofa, propping up in bed to watch TV or read. Tell people to stop that immediately. You're going to get rid of a lot of pain. So you're going to teach them joint protection techniques the first week, gentle mobility exercises. You don't have to do anything mechanical treatment as far as exercise goes until you control the pain. Phase 1, usually we control the pain by the 4th visit. The pain's not gone, it's controllable. Meaning, patient has pain, did you do your stretching? First of all, why did you get in pain? Well, I was at a party too long standing up. I cheated, I laid on the sofa. I went to a restaurant with a bad seat. Okay, there's a reason. Now you're teaching them cause and effect. Then teach them to eliminate those harmful postures and activities. Get them icing 3 times a day for 20 minutes, whether it helps or not, whether they think it helps or not. It's going to help. Patients who ice, in my opinion, get better quicker. We insist every patient ice. We finish every single treatment with icing. So in the first 4 visits, if I do nothing else but educate them about their injury, correct their ergonomics, get them icing and doing some gentle mobility, by the 4th visit, their pain will be controllable almost 99% of the times. Then second phase begins as soon as they say, I can control my pain, I have some control over my pain. It's less frequent, it's less severe, and I can improve it with my techniques. That's phase 2. Phase 2, you start the job of mechanically going after the cause of the problem. So your stretches start to increase in intensity and scope. You're still considering the symptoms. The symptoms are still considerable, meaning you have to consider them in everything you do. So every stretch, 1 or 2 new stretches per visit. Always being sure they don't produce pain. Giving them the disclaimer, if this exercise causes pain, stop it, but continue doing your other stretches that were working for you in the last week. We don't start strengthening aggressively until the symptoms are minimal, unless the strengthening exercises don't hurt at all. You can't strengthen through pain. Pain inhibits muscle function. You can't strengthen a muscle if there's pain still involved. So once we're controlling the pain towards the 2nd and 3rd week of phase 2, then we get more aggressive. Phase 3 begins when their pain is minimal. A lot of patients drop out of rehab. They don't know why they're still there. I'm feeling much better. I have very little pain. Well, you haven't taught them the entire way to fix their problem, the mechanical cause. So while your treatment frequency may go down, and your use of modalities for pain control may go down, but they continue icing, even if they're having minimal pain. My patients continue icing until they're back to their full previous level of function. Even if they have no pain, and they want to go back to biking and running, they keep icing. So in phase 3 is when you're giving them more significant stretching and strengthening because you're going after the mechanical cause of the problem. Phase 4 is back to sports training. You have to see your patients through phase 4. That's why we open phase 4. Because patients who say, oh, my pain's gone, I'm going back to running. Come back a week later, oh, it's back again. What did you do? I ran 5 miles. Human nature does not equip your patients or any of us to do the right thing. We should probably do half as much work as human nature would empower us to do. That's why we're there. So now in phase 4, I'm giving them a walk-run program. Walk for 10 minutes, jog for 2, walk for 1, jog for 2. The second week, it's jog for 3 minutes, walk for 1. And you bring them up, you give them a printed sheet to tell them how to come back because they will go back and re-injure themselves. And when that happens, you know you're on your way to fixing this problem. Look, soft tissue injuries, just like a bone, they take about 6 or 8 weeks to heal. Repetitive soft tissue issues, when they come up, when the pain arrives, that injury could have been brewing for 6, 12 weeks. So it's just getting rid of the pain doesn't mean the tissue's healed. It's your job to teach them to continue protecting the injured tissue until it's fully restored and healed. So getting them back to their workouts, you have to guide them. You have to teach them about the 6 or 8 week rule. Teach them about the importance of maintaining their stretching and strengthening. What happens, they go out and do too much and they get injured, and they go back to the doctor and say, I'm injured, physical therapy doesn't work. I spent thousands of dollars and I'm still injured. You know you had them fixed. They were fixed. They blew it, but that's your fault still. You have to guide them all the way back. People disappear and they stop coming for treatment, you call them. You say, listen, there's still danger ahead. You're not out of the woods. You need to be careful about your approach back to workouts. Please, I'd like to advise you how to do that. In that way, you have a very satisfied client, healed. There's nothing more gratifying than meeting a client who's got an injury, trying to run 10Ks. You teach them a stretching program. I see them 5 years later on the street. How are you? I'm great. I often don't remember their name, but I know their injury. I say, how are you now? I'm running marathons, and I'm still doing the stretching you showed me, and I've had no injuries. 5 years later, 10 years later. I've showed those stretches to my wife and my kid. To me, that's the most gratifying thing. You may think, well, you get less patients, but don't worry, it'll come back, because they're going to tell their friends how you made them pain-free. So, our competition are not our colleagues. You don't want to get patients out of your colleague's office. It's not your competition. Everybody in public has an ache or a pain. Your job is to go out and meet the public and tell them and give them the confidence that you can fix their ache and pain. So don't feel competitive with your colleagues, whether they're in your profession or in an ancillary profession. Your job is to meet the public, find the clients, then refer them to your favorite doctor. I'm so impressed with these gentlemen here. Spent the week with them. They've been really great. You refer them to your favorite doctor, or another doctor, any doctor you think is good. Then you refer enough patients to that doctor, and then that doctor calls you and wants to go to lunch because you sent him 5 ACL repairs in the last 6 months because you're out in the public marketing. A lot of doctors don't like to go out in the public marketing. These gentlemen are very active in community marketing. So you go out and do the marketing, you refer the patient to them, they obviously refer the patient back, and now they're sending you other patients as well. That's how I developed my practice in Santa Monica. That's what my mentor taught me, to market directly to the public. Yeah, we go visit doctors and we make nice with the nurses, but the more important thing is to meet the public. Those are your clients. So you've got a great start here in IPETH. You have a great education, a lot of enthusiasm. Your industry in Mexico is just exploding. And you don't have the competition we have in the States. You don't have to fight with acupuncturists for a piece of the market. You don't have to fight with chiropractors and a lot of other healthcare professionals. You're going to be it. And I'm very excited for Mexico for that reason. So thank you for a wonderful week. These gentlemen especially have been very kind. And all my colleagues that I met here in the last week, I want to say thank you and good luck. I don't know if we still have time for questions.
Just solo dos preguntas. Adelante si alguien tiene alguna pregunta.
I want to know if you maintain the stretching or just as like a movement and like an active stretching always?
Is your question, I'm sorry, is your question static stretching versus active?
Or it's always active, or you have like maintaining stretchings like the
static stretching.
classic?
Yes, no, I believe in the importance of static stretching. Static stretching improves the range of motion of the connective, or the length of the connective tissue. It helps the connective tissue adapt to the stress of the training, and it gives us the range of motion we need to get into proper mechanics for our sport. That's the #1 reason why we stretch, so you can attain the proper mechanics of your sport or your daily activities. Let me give you an example. If the hamstrings are tight and your mom goes to pick up the laundry, the hamstrings are going to keep the pelvis stuck, still here. now all the movement's occurring in the spine. If the hamstrings are flexible, pelvis tilts, spine is flat, I'm able to move. If I can squat, it's a range of motion we need to maintain. I know that the connective tissue studies show that static stretch improves the permanent deformation of the connective tissue. And I think those studies that show active warm-ups are better than, or should replace static stretching are ill-advised. First static, no one static stretches and then gets on the track and runs 100 meters. So to me, it's a moot point. We static stretch, then we do drills, which is active warm-up, then we run. So I think those studies were faulted. And now I have trainers saying to everyone, don't stretch, and they're just lazy. They don't want to spend the time stretching. The public doesn't want to stretch. It's your job to teach them how important it is. We did the stretches yesterday in 4 minutes, the whole body, and we were ready to go. So a coach or an athlete who says they don't have time to stretch, it's just not true. You have to prove that they do. Go there, show them, quick release of each muscle. Those are quick releases that we do before and after workouts. If we want to improve flexibility, then we might have to hold a longer static stretch.
And my other question is, if you try this technique with patients like neurologic or something like that, not just athletes?
Well, you know, in the neurological population, we're more likely to use the contract, relax, antagonist and agonist, you know, inhibition and stimulation. And so we're more likely to do more of that. I also, even for my elite athletes, I don't stretch them. I don't take their leg and stretch them. They have to learn to do it. I'll work on their muscle and free it up. Now, there's a couple of exceptions to that. When there is scar tissue from an injury, especially in the hamstring, more than others, you'll have an athlete come in and say, I have this pain in the back of my leg, it's vague, I can't figure out, it might be at the knee, and the more I stretch, the tighter it gets. And that's because the scar tissue is just like one of those Chinese finger handcuffs, when you put your fingers and you pull and you can't get out. It tightens in a similar fashion. So when people get chronic scar tissue, they need help with the friction massage. They need help with the foam roller to break the adhesions between the fibers. Gentle stretching, and then more work that way. So I'll tell people with hamstring strains not to stretch so much. It's different though. The adductor muscle group, when it's strained, it reacts, I think, on a basis where it tightens more. And so I will have them release the adductor, and I don't find that it gets tighter with stretching. But the hamstring does. So, but in general, if someone stretches and they feel tighter, it's an indication they have an injury brewing, scar tissue formation. They can learn to massage. So I'll tell them to just massage it or use a foam roller rather than doing a lot of heavy stretching. The stretching should also be governed by the subsiding tension principle. The idea is not to go as far as you can go on a stretch. I can go all the way to my kneecap, but I feel a stretch right here. I tune into the tension, and then I either go further, or if it's increasing the tension, I need to let up. If it's decreasing or staying the same, I might go a little further. But if I go too far, and you can try this for yourself, now the tension is building higher and higher in my muscle. I'm overstretching. And again, human nature will have people overstretch. Athletes will take the same workout mentality to stretching. Stretching is an act of relaxation. The muscle has to be relaxed to get to the connective tissue elements that we're trying to stretch. So stretching is about relaxation, breathing, mostly non-weight bearing. Doesn't make any sense to stretch the hamstrings like this, because the hamstrings are contracting to keep me up. Otherwise I'd fall on my face. So a little bit of that after I've done my static stretching as part of a more dynamic stretch, maybe. But this is not a good position to stretch the hamstrings. It should be non-weight bearing, gentle stretch, tune into it, and then adjust.
Bien, ¿alguna otra pregunta?
Bueno, ¿qué tan importante es el tiempo? Porque ayer fuimos a un taller, igual se llama amplitud de movimiento a base de flexibilidad, y era sobre estiramientos. Entonces, el ponente que nos dio el taller nos mencionó del tiempo. El tiempo es muy importante. Entonces, yo quisiera saber el tiempo.
I'm not quite sure what to make of that research, and I certainly respect my colleagues in their research and their science. What I can tell you is that for 33 years, my athletes have been static stretching, holding for 10 seconds, when they want to get a quick release, 30 seconds or 60 seconds or 2 minutes when they need more permanent improvement in the tissue. But specifically before performance, my athletes do their static stretching, then they do their dynamic warm-up. But if they're still tight, you'll see Dawn Harper, you'll see her in the Olympics in Rio de Janeiro. She's a gold medalist and a silver medalist in the hurdles. And when she's still tight, she's going to put her foot up on the hurdle, and she's going to stretch it 2 seconds before she gets in the blocks. And then she's going to run and win the gold medal. So all I can tell you is the results we have with our clients. I'm not a researcher, and I really appreciate how difficult it is to do research. I can just tell you what we've applied and the success we've had. When I've taken stretching techniques to a team, like the high school soccer team, static stretching, 2 repetitions, 20, 30 seconds, we've eliminated so many injuries. So maybe there's a better way to do it. Maybe we'll learn that through the research. But I can tell you the way we've been applying the programs has gotten results in very closed environments where there was a lot of injuries before, and now the injuries are reduced. So as a clinician and not a research person, I have to go on what works for us in the real world. The more science we get, the better we'll understand what we're doing. But I do have a little problem with research dictating what's done. For instance, in America, you know baseball is a big sport. Baseball coaches have been icing the pitcher's elbow for 50 years. They didn't need science to show that cryotherapy and icing improved recovery. They knew if their pitcher didn't ice, he wasn't going to pitch in 3 days. So what we see, the people who are in the trenches, where the rubber hits the road, we're dealing with athletes, the careful ones. If it makes sense and it works for them and the science supports it, that's the best thing I can go for.
Bien, pues a nombre de IPET y del comité organizador del Congreso, Bob, queremos entregarte este pequeño diploma. Yeah, that's fine. Y brindémosle un fuerte aplauso a Bob por todos sus conocimientos.